I'm Charles Kanan, Senior Provider Education Consultant with Palmetto GBA. Today, we're going to talk about the certifying physician's role in home health. Now, Palmetto GBA advocates the health information supply chain concept, and that is a concept where it takes many entities to work together to have a successful product. So in this case, our successful product is a home health record that meets billing requirements and documentation requirements. So it takes physicians, nurses, therapists, social workers, home health aides, coders, billers, and compliance people to make this supply chain be effective. So today, we're going to talk about the front end of this process. We're going to talk about the physician's role. Whether we're talking pre-claim review, a record request from a Medicare contractor such as CERT or ZPIC, or a regular ADR, the physician's documentation is key to the home health agency getting their reimbursement. So what we're going to do, we're going to begin with an overview of the home health benefit. Then we will focus on the face-to-face encounter documentation. We will touch on the plan of care, certification and recertification. Then we will finish talking about care plan oversight. When someone is looking to be a part of the home health benefit, there are things that have to be in place. A person receiving the home health benefit needs to be someone that is not sick enough that they need to be in a facility, but they are too sick to be in an outpatient service. So they're in that little space right in the middle. So there are certain requirements they have to meet. The individual has to be what we call confined to the home. So we also call that homebound. So when you're confined to the home, that means leaving the house is very difficult. It's either exhausting, taxing, you need someone to help you. It's just not easy to get around. The other pieces of the home health benefit is the patient has to be under the care of a physician, which is what we're going to talk about today. A plan of care has to be established by that physician in collaboration with the home health agency to make sure all the beneficiaries' needs are met, and the person has to be in need of some type of skilled services that require a healthcare professional as opposed to a layperson to complete. The patient also has to have a face-to-face encounter. What is a face-to-face encounter? That's a very interesting story. So let's go back in history and tell you how that came to be. If you go back before the Affordable Care Act, individuals seen at home, so we're talking home health, hospice, and your durable medical equipment, patients were referred to those services, and many of them were not seen by a physician. So there were individuals that were not appropriate for that benefit. So the Affordable Care Act enacted a rule that all of these patients had to have some type of face-to-face encounter by a physician to verify their eligibility for that service. So for the home health benefit, the individual has to see a physician either 90 days before home health services start or within the first 30 days of start of care of the home health benefit. The reason the person is seen by the physician needs to line up to the reason that they need home health services. That physician can be a physician, it can be a non-physician practitioner also. And remember, the intent of the face-to-face encounter is to validate that the person is eligible for homebound services, they need skilled care, and home health is the appropriate service for them. So, certification, what does that mean? The certifying physician has to certify that the patient meets the requirements that we have just discussed. So they have to have a need for skilled care. Skilled care means skilled nursing, physical therapy, or occupational therapy for the initial service. Now they can have supplemental services such as home health aid, social work, or occupational therapy if needed, but nursing, PT, or speech-language pathology have to be the primary need. The person has to be confined to the home, so the certifying physician is certifying that that is the case. The certifying physician also does sign that plan of care that is put together in collaboration with himself or herself and the home health agency. The physician, we have said that name several times. What does physician mean in this case? The physician can be someone that saw this person while they were in the hospital or a post-acute facility, such as a skilled nursing facility, or it can be a physician that saw them in his outpatient office. A non-physician practitioner can also perform a face-to-face encounter, and those that meet that requirement are a nurse practitioner or clinical nurse specialist, a certified midwife, or a physician's assistant. Now, this needs to be somebody, when we're talking about our non-physician practitioners, that have a working relationship with that primary physician naturally. It cannot be an independent practitioner that was just hired for the sole source to do a face-to-face requirement. So if this face-to-face is completed by one of these other physicians besides the certifying physician does have to acknowledge that he knows the face-to-face was done. So he or she could just co-sign that document, or he could write a statement acknowledging that he knows the face-to-face was done by, for example, the hospitalist or a non-physician practitioner. This is called handing off. So you can have more than one physician involved in this home health process. So if another physician starts the process, let's say the hospitalist begins by doing the face-to-face and ordering home health services, the patient's primary physician, or we call it community physician, will take over, generally speaking, sign the plan of care, and continue to follow that person throughout their home health services. So, just for review, the face-to-face encounter can be performed by the certifying physician, or it can be performed by another physician in a facility, such as a hospital or a subacute facility. So you can have plenty of physicians involved in this process. And remember that the non-physician practitioner has to be somebody that is in collaboration with that primary physician. And don't forget that there has to be a partnership. The partnership has to be with that nurse practitioner, that physician's assistant, and that primary physician. So when you are turning in records for review, it has to be obvious that these partnerships and these handoffs have taken place. Some people put that as part of their plan of care, and we will discuss ways to make sure you can do that in later videos. But it is key to show communication between the hospitalist or the non-physician practitioner and the primary physician, because the certifying physician at the end of the day is the one that is responsible for the patient's care. We've said encounter several times. What is the word encounter actually meaning? This is a problem-oriented document, which means it has the reason the person needs medical care. So basically a history, a summary of physical exam or physical findings, and a plan. The person needs skilled nursing, they need physical therapy, what have you. Those are the elements that are required when we say a quote-unquote encounter. Now the Medicare Matters article SE 1436 has 4 examples of what a face-to-face encounter may look like. So there are several different versions depending on whether the patient did see the physician. And remember, this encounter has to be related to the reason the person is receiving home health services. Now, those of you that have been in home health for a while, you are used to seeing the good old face-to-face form that started back in 2011. That form is no longer a requirement, though a lot of agencies still like to use it. If you are using that face-to-face form, that is good supplemental information, but it does not meet the requirement by itself. You still have to provide the actual visit where they were in the hospital or they were in the doctor's office, or that home health claim will not be payable. So again, to reiterate, that form by itself that just fills in the blanks is not acceptable by itself. Some other sources of denial or lack of payment have come from poor documentation. The diagnosis by itself does not support somebody needing home health services. For example, I want to admit to somebody to home health because they have high blood pressure. This person's probably had high blood pressure for 20 years. Why do they need home health today? So we're looking at a change from the person's baseline. So you need to have symptoms described. So I have high blood pressure, my head is hurting, I'm fainting, I'm dizzy. That is the type of documentation that is needed to tell this story. A surgical procedure by itself does not support home health services. Now, the natural description of the outcome will help you out. I had a knee replacement. As a result of that, I cannot bear weight on that leg. I'm in a lot of pain. I need crutches. You have to have those details at the end to justify the home health services. Simply regurgitating the regulation saying my person has a taxing effort, it's difficult to leave home. You have to tie that to a medical reason. The regulation says illness or injury is why you need home health services. If you're painting the picture that this is just an older person that's just slowing down because they're just getting older, that claim will not be payable. If the person has an abnormality of gait, that was a common diagnosis in ICD-9, what does abnormality mean? Be specific. Is that person having a Parkinsonian shuffle? Does that person need to lean against a wall? Is that person stumbling a couple of feet then falling? Just give us a little more details. And weakness. Weakness as evidenced by what? Weakness is a good start, but we need to know what weakness means. They are weak because they walk 5 feet and they can't breathe. That's good, but weakness by itself is not going to be payable. So to put this in a nutshell, acute symptoms versus a chronic disease. That's probably the most important point I need you to take away from this little session. Most of your people are going to have a chronic condition, probably 95% of them. What is going on with that person that they need home health today? What symptoms are different from that baseline? If you are communicating that, you will be 95 miles down the road and most of your work will be done. Now, the home health agency may send you several documents to sign off on, and you may wonder, why are they sending me all these sheets of paper? I'm going to tell you why. The home health agency does an assessment of the person in their home. So they are going to see some things that you will not see while you were in the hospital or you saw this person while they are in your office. So they will have information related to the person's living environment, such as steps, stairs, things like that. How far it is from their bed to the bathroom is 50 feet. They can only walk 10 of those feet, things like that. So they will have a few extra details from their natural assessments. And they may send those documents to you to sign off on to help support the home health benefit. So don't be offended. They're not trying to tell you you didn't do your job right. They just have extra information because they're doing an in-home assessment and they're just giving information just to give a more complete picture. So the certifying physician just needs to sign off on those documents, and they should incorporate those in your natural record and send a copy back to the home health agency so they can submit that for their record being reviewed. The next piece of documentation involving the physician is the plan of care. The plan of care is a list of orders, medications. It's basically the treatment plan for that patient. So this is put together in collaboration with the physician and the home health agency. This has to be done every 60 days and it needs to be signed before the agency can bill. So you may feel like this agency keeps badgering me about this document, and they're going to continue to do that because if that document is not signed by the certifying physician, that agency cannot get their reimbursement. So it is very important that when they send those documents to you, that you sign them, date them, and return them as soon as possible. A signature without a date is invalid. So if you sign it, don't put a date on it, they're going to send it back to you to put a date on it. Now, if a patient is being recertified, meaning that they are going to continue the home health benefit for another 60 days. Recertification requires an extra statement. We just need a statement that says this person is expected to need skilled services for X amount of time. So that is something they're going to also ask you about. It can be in days, weeks, but it has to be a quantifiable time frame. It cannot say until the patient gets better, until they die, or until they're discharged. We need something that is quantifiable. So that is something they're also going to ask you for every recertification. So please make sure you cooperate with the agency and provide that information to them. This is something that has to have your signature on it. So some people are putting it on the plan of care because that's a document you're naturally signing. Some people are putting it on the order to continue services. However you and the agency want to work that out is up to the two of you, but it does have to be documented that this patient will need skilled services for at least one more episode. If you're summarizing this information for medical necessity, we did a focus group that tried to put this in a nutshell. So the focus group consisted of physicians and home health providers, came up with 4 questions. What are the structural impairments? What are the functional impairments? What are the activity limitations? And what is a nurse or therapist going to do about it? Body structures are basically the anatomical makeup of the individual. So a structural impairment is going to be a deviation in that person's anatomical makeup. You will most likely see this with wounds. Those decubitus ulcers or diabetic ulcers are going to be a classic example of a structural impairment. A functional impairment is physiological in nature. So that's going to be a change in their cardiovascular system, respiratory system, what have you. Now, all of your patients may not have a structural impairment, but they should all have a functional impairment because the home health agency is trying to remedy some type of symptom. So whatever that symptom is, the body system that related to that should be where your functional impairment is. Your activity limitation. This is where you support the homebound services and your need for your therapist. Your patient has some type of need that needs to be fixed. The easy way to measure that is look at what they do from day to day. They have to try to walk to the bathroom, they have to feed themselves, dress themselves. So just explaining what tasks they cannot do meets this requirement. It's very easy to do because it's very visual and also it has a beginning and an end. You'll easily be able to tell if somebody buttoned up all the buttons on their shirt or if they can walk from the bedroom to the bathroom. So you have met that requirement by having a measurable problem and you can have a measurable solution. So going back to what I said in the beginning, remember you're going to have an acute flare-up of a chronic problem. So those activity limitations are going to be a perfect way to tell that story. My person has had congestive heart failure for 10 years. Normally they can walk about 500 feet before they get tired. After this flare-up, they can only walk 10 feet. Perfect way to tell that story. Think of before and after. Before I had this problem flare up, I was here. Since it's flared up, I can only go this far. Perfect way to justify home health services. And here are just some examples based on the different functional systems. You see for the cardiac system, what is the difference from this person's baseline? They're tired when they're just walking a couple of feet. They're having shortness of breath just sitting watching TV. Unless their football team is losing, but that doesn't count. Shortness of breath at rest. They can only walk around the corner, only walk to the bathroom, then they get tired. These are things that are very measurable, and when this person's symptoms resolve, you can document how they can walk faster or that shortness of breath isn't there anymore. So perfect way to justify the need for service, and it gives you a recipe to show how the home health services are effective. Respiratory symptoms are going to be very similar. It's going to reference the person having shortness of breath. You can also look at how many words they can say before they get fatigued or before they run out of breath. Musculoskeletal issues. How far can the person walk? Can the person bear weight? Is it painful for them to walk? Are they walking with bad balance? Do they need crutches? Do they have to lean on a person? Do they have to lean on the wall? These are very simple things to describe. Your diabetes patients. There are a whole lot of folks out there that are going to need home health for diabetes. You need to tell a story about what those symptoms are that need to be remedied. If the person's blood sugars are going up and down, your documentation just needs a history of some of those readings. If the person has trouble giving their insulin, explain why. The person has bad vision. They can't see those little lines on the syringe. Perfect reason to have home health give the insulin. The person has Parkinson's. Their hand is shaking. They can't manage the syringe. The person has a stroke. Again, there are various reasons why people cannot give their insulin or their blood sugars are out of control. Just tell that story and the person will meet eligibility. And just some other general activity limitations we mentioned. And once again, these are things that are naturally assessed by the home health agency, so they may ask you to sign that comprehensive assessment. They naturally do an assessment on the person's ability to dress, feed themselves, transfer, and ambulate. So between the agency's documentation and the physician's documentation, we expect to see the activities this individual cannot perform. We do have a plethora of education on our website we would like for you to take advantage of. We have many articles on the Palmetto GBA website. So when you go to our website, palmettogba.com, make sure you're on the side that says Medicare, and you will see it broken down by Part A, Part B, and Home Health. So you would go to Home Health, and we have several tabs that are beneficial. There's a pre-claim review tab that has information. There's a face-to-face tab by itself that has great information. It has articles. We also have a video which talks about some tips on how to document, and it's on YouTube. It's about 5 minutes long, so it's a very quick video for new staff or for refreshers on documenting medical necessity for the home health patient. We also have a checklist that we have put together for the home health agencies, but it's great for the physicians to use this also to learn what is expected of the document, and also as a QI type thing. Did I mention why they need skilled services? Did I mention symptoms related to homebound? Things like that. So that's also an excellent tool we recommend that you use. The pre-claim review section has also many references. The user's guide has information on what is being looked for a pre-claim review. It also has several checklists there, so that is also a good resource. We have general resources that relate to pre-claim review also. Some of them are CMS frequently asked questions. We have information on our website about that. So again, please take advantage of those sources. We're now going to talk about care plan oversight. Care plan oversight is when the physician can bill for reviewing the care plan for these individuals. Now, care plan oversight does apply to home health and hospice patients. The rules are exactly the same. So if you deal with hospice, you can also use these same guidelines. The point of care plan oversight is these individuals in the home have a multidisciplinary care plan, meaning you have several disciplines involved: nursing, social work, therapy, what have you. And a physician needs to oversee these to make sure that the results are what we desire them to be. The way to build this is through the HCPCS codes, either G0179 for a recertification or G0180 for a new certification or a start of care patient. How to build these services: you use the date of service that you are assigning that certification document, which is generally the plan of care. So whatever date that is, it needs to be the same date that you submit on your claim to bill. The same physician that is a certifying physician needs to be the same physician NPI that uses the claim to bill. You have to make sure that you are relating your billing to the time frame the person is being seen. A 60-day episode, January and February, for example, you cannot bill care plan oversight for sometime back in November. It has to be related to the 60-day episode during that time frame. Care plan oversight is a timed code, so as you know with time codes, you have to have the time. We're looking at 30 minutes of managing the person's case. This is what they call a non-patient code, so the patient is not going to be there in the office. It's review of records and things along that line. Now, we are only talking about physician time, so nursing staff time in the physician's office that is involved, that does not count. Any type of filing, Xeroxing records, that does not count. You have to make sure that you do document the time. Like I say, time code has to have the time, so just don't overstep that. That's easy to forget. Make sure the time and the date are part of your record for billing purposes. Now, your non-physician practitioners can perform the actual care plan oversight. This will function the same way physicians and nurse practitioners and PAs do incident 2. So it's the same exact process. You guys should be familiar with that. So basically, your non-physician practitioner does record reviews and they collaborate with the physician and conference on the person's needs. So it has to be a collaborative effort. The nurse practitioner cannot do it himself or herself without the primary physician being involved. And remember, the NPI used is going to be the certifying physician. If you try to bill the NPI of the nurse practitioner or the PA, that is incorrect. Now, as with any CPT codes, you cannot double dip. So, if you are working with somebody who is discharged from a facility, an inpatient facility, a nursing home, observation, anything like that, you cannot use the same documentation for the inpatient facility discharge and the care plan oversight. You have to have documentation to show these were two separate actions. Things that you cannot bill are going to be situations such as something that is naturally covered by a global period. What is a global period? When an individual has a procedure, the fee schedule, basically how the physician gets paid for that procedure, has a global period, either 0 days, 30 days, 90 days, where all services connected to that procedure are wrapped up in that surgical procedure billing. So if you have a procedure that is a global period of 30 days, then if you try to do something with care plan oversight during that time, it's going to reject because it is falling during that global period. So please keep an eye on the fee schedule. Make sure you know what the global period is so you can bill correctly. There's just a few things that you can't count. I've already mentioned filing, Xeroxing, driving from point A to point B. Things that are not actually related to reviewing the record are things you cannot bill for care plan oversight. And we have some references on the slide just to make sure you can have a point of view to make sure you're billing it right in the documentation requirements. So we've gone over a lot in this little time period. We talked about the certifying physician, his role in the home health entity. We talked about the face-to-face requirement. We've talked about recertification. We've talked about care plan oversight. If you follow the things we discussed on this video, you will have a successful endeavor in the face-to-face world. It does take a little bit of coordination between the agency and the physician's office. So again, going back to the health information supply chain, everybody has to coordinate, has to work together to make sure that this documentation is complete for the home health agency to bill. But I feel confident you guys can do it. You have some great information. I know you guys all want the beneficiary to receive the services that he or she should receive, because that's what it's all about. We all want to see the beneficiary getting taken care of. And always remember, Medicare ends in I care. So we care too. Okay, that was kind of corny, but you know what I mean. Everybody wants the person to receive the proper services, and we want the agencies and the physicians to be paid appropriately. So I'm Charles Kaner from Palmetto GBA. Thanks for watching this video.